Thank you very much, and good morning. It's a real pleasure to be back here in Riyadh and to visit with some old friends and to make some new ones. We have a busy morning schedule set up, and I'll try to go through the topics reasonably quickly without making it a video. And I would welcome questions or interruptions as they arise. Since it's a small group, I think we can be informal, and I'll try to get through the most of the material. All of this is available. I'm not sure whether they've put it on a website or a hard drive or a flash drive, but I think that this is available if you're interested in some of the references. So we'll start and talk about prenatal hydronephrosis, one of my long-standing interests and certainly a major part of what we do in pediatric urology today. We know that prenatal hydronephrosis and prenatal genitourinary abnormalities are common, about 1.5% of all pregnancies, and at least half of these are due to hydronephrosis or some sort of dilation phenomenon. And within this group, obstructive uropathy is a major element and is, of course, the single largest cause of renal failure in boys under 4 years. So this is not a trivial issue. And of course, for those of you who have gray hair like I do and remember the onset of the application of prenatal ultrasound in clinical practice, this has really completely changed the face of pediatric urology in the last 2 or 3 decades. And we are still working with how to manage it and deal with it on a regular basis. And the real difficulty is dealing with the large number of prenatally detected urinary tract abnormalities. How do we manage these? How do we make decisions? How do we selectively evaluate them prenatally and perinatally? We don't want to overtest, but at the same time, we don't want to miss kids who have a significant issue and may benefit from testing. And what I have found in doing this over the years.
Kill the feed from the pediatrics room, please.
There we go. There's a great deal of subjectivity and opinion in how we manage these, and in some ways I have asked the question, is this all really in the eye of the beholder? And do we have any solid facts that we can work from in making our clinical decisions? I'm sure you're all aware of the various grading systems that are used in prenatal hydronephrosis. The Society for Fetal Urology one is the most common probably. I have a lot of problems with it. I don't really like it, but there are no really good alternatives. I have used a descriptive one for years, mild, moderate, moderate, and severe. But that too is rather subjective. So we have no simple objective method of grading the degree of hydronephrosis. We'll talk about a new effort recently, but I don't think it's going to substitute yet. I don't think that simple measurement of the anterior-posterior pelvic diameter is useful enough because it does not reflect the state of the calyces. And I'll go into this a little bit, I think looking at the condition and the degree of dilation of the calyces is the most important predictor of the obstructive significance. This is just a graph showing the relative frequency of the various diagnoses in a registry that we ran in Boston of almost 2,000 patients. And clearly the UPJ configuration, that is no ureteral dilation, no other abnormality, but pelvic dilation, is by and large the vast majority of it. But you still see significant numbers of others that we have to take into account and be able to identify those clinically. So the differential diagnosis of fetal hydronephrosis is fairly wide. I think most of you would know it, but I think it is useful to go over this very simply. This is mild and moderate, and I don't know whether I have a laser here. No, it doesn't show up. So relatively mild with minimal calyceal dilation. What I would call moderate is with calyceal dilatation in each of the calyces, but it's not profound, it's not everting, if you will, and that would push us into what would be the SFU grade 4, where it's more significant and dilated. I think duplication is the diagnostic group that challenges many people. can be generally identified prenatally, not always. It depends upon the quality of the image. And we certainly want to recognize whether there's dilation of the upper pole or lower pole. That obviously will change the various possibilities. Is the ureter dilated? Do you see a thickened bladder, or is it normal? Or do you see isolated hydronephrosis and with no dilation, and typically that's, of course, with the lower pole. When we look into a duplex system, some of these pictures are shown here where you can see the clearly dilated ureter. You can see that it's involved in the upper pole and not the lower pole, which is in red, and then the dilated ureter is shown in the blue, and you can see the convoluted nature of it. And then, of course, once you see this in the kidney area, you want to look in the bladder, look for any sort of an intravesical structure, such as a ureterocele, as we see here. And all of these can be seen both fetally and prenatally. Bilateral hydroureteronephrosis with a thick-walled bladder and a dilated posterior urethra, the so-called keyhole sign, of course, that says this is posterior urethral valves until proven otherwise, and we have to treat those boys certainly with greater care and anticipation, and would certainly want to have them evaluated relatively soon after birth rather than waiting as we might with other lesser degrees of dilation. Now, there's been a recent publication that I'm sure you're familiar with, the Multidisciplinary Consensus on Classification of Prenatal and Postnatal Urinary Tract Dilatation, the UTD classification system. And I have read through this, I trust many of you have. It's, I think, a well-intentioned attempt to permit more consistent communication about prenatal hydronephrosis. Unfortunately, I'm not sure it has accomplished that, and I still struggle with understanding how to interpret this and what it means. I'm not going to spend a lot of time going through this because it is complicated. What they're trying to really do is set up risk stratifications for kids prenatally and then postnatally to guide evaluation and management decisions. And it really is based on a lot of the things we've talked about: the degree of calyceal dilatation, parenchymal thickness, parenchymal appearance, dilation of the ureters, appearance of the bladder, and any oligohydramnios. And you put these into 2 risk groups or 3 risk groups, depending upon what you see. Unfortunately, none of this is strictly linked with clinical outcomes, and this is our problem. And this will be the theme of my talk, is that unless we link these observations to clinical outcomes, it's not going to help us make good decisions. Postnatally then, and this is typically greater than 48 hours after birth, you don't want to rely on an early ultrasound unless you're worried about bladder outlet obstruction. If you really have an appearance typical of valves, then you need to start your evaluation or at least get drainage accomplished relatively soon. But really, they're using the presence or absence of calyceal dilation and dilated ureters to increase risk level, or abnormalities of the renal parenchyma. To my mind, these are all pretty obvious, and I don't think that they are segregated enough or fine enough to allow you to discriminate between whether we do certain imaging studies, and that's the difficulty. Finally, they do extend this into postnatal management, but if you look at these, it's almost all discretion of the clinician, discretion of the clinician. And even those that are beyond that are simply recommended rather than a standard of care. And when we look at trying to create clinical practice guidelines, if you don't have some degree of standards of care or strong recommendations, it's very difficult to get any guideline to be useful. So I think this may be a useful foundation, but it has to evolve. And that we are working on that in a number of different ways, at least from the imaging standpoint. The way I look at it is there are a few subcategories where postnatal evaluation is essential. We'll call it a no-brainer. If you have evidence of an ectopic ureter or a ureterocele, those children need structural, functional, and bladder evaluation. If you have moderate to severe bilateral hydroureteronephrosis in a boy, these kids have to be evaluated early. That is posterior urethral valves until proven otherwise. If you have severe unilateral hydronephrosis, SFU grade 4 or diffuse kaliectasis, thin parenchyma, those kids need functional evaluation. If you see a dilated ureter you're going to need to evaluate for possible obstruction or reflux, and therefore you're going to choose your tests based on those decisions. The difficulty comes in the sort of lesser degrees, and this is really, should we screen for vesicoureteral reflux, and in whom? Do these kids need prophylactic antibiotics at birth? How should we evaluate for obstruction, and how do we make clinical decisions? And which of those patients need surgery? And I'll try to touch on those. I can guarantee you I'm not going to give you a definitive answer, but to give you some information on how to best make decisions as you go forward and still use clinical judgment. So prenatally detected reflux was a very obvious thing as we first started doing prenatal imaging, and we thought this would be great. We can identify these kids before they have their first infection and potentially before they have the big bang that is going to potentially damage their kidneys. We know that prenatal reflux can create kidneys that are not normally developed. We don't know whether it's cause or simply association. That's another debate. And the benefits of screening would be obviously to identify those kids with reflux before they have an infection and damage their kidneys. There is a burden of screening, though, is that we may identify patients with low-grade reflux with little risk of renal injury, and therefore we have over-tested and overburdened the child and the family and potentially created problems in that regard. So what are the data? And a number of studies going back a number of years is in the context of perinatal hydronephrosis, reflux is present in a significant number of patients. There's no question about that. What you define as significant then becomes subjective. In the Zarin study of 1993, there were 130 patients, and they found reflux in 38%, and including reflux in 25% of kids who had normal postnatal ultrasound studies. So that the identification of some dilation was a warning flag that reflux was potentially present. In the ARENA study, it was 18%. Brophy study, it was 17%. In a large group, when I was in Boston, we found it in 26%, just of the kids with mild to moderate hydronephrosis. So this wasn't the severe kids, and we had no clinical predictors that could exclude reflux, and that was part of our problem. We figured, well, if we see greater than SFU grade 3 or 2, then maybe we should do the screening, but it didn't seem as if severity of dilation correlated with reflux incidence. This was a paper by Rich Lee, still in Boston, and they looked at the severity of dilation prenatally and postnatally and the likelihood of either an obstructive process or reflux, and with increasing severity, you had a greater chance of an obstructive process in blue, but reflux was not significantly increased in that group. When we looked at this question when we wrote the AUA reflux guidelines, which we published in 2010, the incidence of reflux in a large number of studies was 16%, and this comes out pretty well. I think that's a reasonably good number. There was no significant difference by hydronephrosis severity, no significant difference by sex, and 2/3 will have grade 3 or higher reflux. So it's not trivial reflux. 50% of those with grade 4 or 5 will have pre-existing renal cortical abnormalities. So this is congenital reflux nephropathy. It's not from pyelonephritis. So does that still mean that we should look for it? Is this clinically important reflux? And that remains the question. Ismaili's study in 2002 suggested that in a fairly large number of infants with dilation, if they had 2 normal postnatal ultrasounds, the VCUG was only abnormal in 6.7%. So maybe we can use serial ultrasounds if they're normal. However, what happens if they have persisting dilation? Then maybe you should be doing the VCUG. So we certainly can select a low-risk population based on postnatal imaging. And certainly in Boston, our impression was that children who had mild to moderate perinatal hydronephrosis but were not screened were doing fine. So we gave up doing VCUGs for a long time and didn't seem to have a problem. But we decided to look back at that. This was in essence a serendipitous experiment, and we published this in 2009. And we really looked at those who had no screening and therefore had no prophylaxis versus a very comparable group who had been screened. We had a reflux incidence of 28%, So we made an estimate within the population that had not been screened, how many should have had reflux and how many might have had infections. And what we saw was clearly a difference in incidence of UTI in these children who were not screened and who did not get prophylaxis, with an odds ratio of 8.9. So that's significant. Clinically, and is the question. And a number of challengers to the article said, well, that's fine, but does this matter? And we're still left with that question. I do think it's significant, but I can understand that some people would say, well, it's not the impact of this may still not be significant enough, even though we had clearly the ability to prevent infections. So one could certainly argue that a VCUG can be recommended for all patients with some degree of prenatal hydronephrosis to minimize the risk of renal damage. Now, of course, that depends on the fact that you believe that prophylactic antibiotics can prevent renal injury and reflux, and I know that's another debate. That's the next talk, I think. So, therefore, until the VCUG is obtained, if you're going to get it, I do recommend prophylactic antibiotics are recommended as well. So that's the group that I will put on prophylaxis. If a VCUG is not to be obtained, which is not unreasonable, then I think the family has to be made aware of the clinical signs and symptoms of a UTI. You need to be comfortable that they're going to actually follow up, and you need to know that their primary care physician is aware of this. That's not unreasonable. I don't think we have to test everybody. A follow-up ultrasound is useful, which we're going to probably do anyway to assess renal growth, the degree of hydronephrosis, and ensure that the child has been well. And I do think the chance of missing significant reflux is probably small. It's not zero, but it's small. And I think this is a reasonable approach as long as we are careful and informed with the family. So what about obstruction? This is the other big controversy. With a big dilated kidney like that, which this is, for those of you who are younger, that's an IVP. Maybe you guys still get to do them here. We're not even allowed to do IVPs anymore, which is too bad, because I do think it's a good test in some situations, and we by and large rely on the MAG3. But these are the kidneys that challenge us. Do these need surgery? Are they going to get better? That controversy has yet to be settled, and we're still looking for good biomarkers. But functional testing, which really today is radionuclide renal imaging, should be used, to my mind, when the severity of the hydronephrosis is such that functional impairment might be present. And exactly where that is not perfectly defined, but I think that should be important. You don't need to do a MAG3 on every single kid with dilation. And really, this is more than just moderate hydronephrosis. Caliectasis should be present in all of the calyces, or the renal pelvic AP diameter is greater than 20 millimeters. If it's less than that, the chance of you finding functionally significant obstruction is, I think, quite low. Now, part of the problem, we have to recognize that although the MAG3 is our gold standard, it has relatively limited validation with long-term clinical outcomes. Keep in mind that the functional measurement, which is really the differential uptake of the right versus the left, is the basis for most clinical decision-making, but it does not reflect a lot of the components of renal function, such as tubular function, concentrating ability, acid-base handling, or its endocrine functions. So be careful about assuming that that relative uptake number truly means renal function. It's part of renal function. Interpretation of the washout time is highly variable. We wrote a paper back in 2000 looking at 3 different mathematical formulas for calculating washout times, and we get 3 different numbers for individual patients. So be careful about that number. I really encourage all of my team to look at the imaging, understand how the test is done and how it's interpreted, and don't just simply read the number. The imaging assessment is not really well correlated with pathological outcomes. We published a number of papers on doing biopsies of kids with UPJ obstructions who were having surgery and correlated their histology with what we saw on the MAG3. And unfortunately, even those with good uptake did not always have normal pathology. So it may well be that the kidney's good at compensating, it looks good clinically, but it may actually be under stress and may actually reflect the potential for ongoing damage. The MAG3, though, is really the best we have, and it's a very useful baseline for observational follow-up. We did a quick study of 29 patients who had mild to moderate hydronephrosis, so not very severe at all, and all of them had relatively normal function, Washout times were somewhat variable, which you'll see even in those with good function. And there was no significant difference in the results between the grades of the hydronephrosis. So mild to moderate, I typically do not do a MAG-3 unless it worsens. And in that mild to moderate group, we also could see a steady improvement over time. And what I tell parents is that it takes about 1.5 to 2 years for most of these, for half of these to go away, which means the other half are going to take a little longer, but not a big deal. These kids are not having pain, they're not having infections typically, and I don't think this has a long-term functional impact. So you need to just be patient. A lot of pediatricians get very impatient, but this is what most of the studies over the years have also shown. Now, as I mentioned, as you're interpreting your ultrasound and making a decision about looking at function, I really think that calyceal dilation may be your best indicator of severity. I have seen kids with big dilated renal pelvises that are extrarenal but minimal caliectasis. I don't think they have significant obstruction. I think those kidneys are probably going to be okay. The renal parenchyma should be less echoic than the liver or spleen. And then thinning of the parenchyma may reflect only dilation. It takes a lot of thinning before you ever actually see a functional loss. It will happen, but just because it's thinned out does not mean the function is down. And be careful, as I mentioned, of the extrarenal pelvis that may look more severe than it is functionally. Now here's just an example of using the MAG-3 serially for follow-up studies, and you can see in the affected kidney actually extra function at 68%, and then relatively decent washout, and then well, actually, the affected kidney was 39%, and then over time, it really only about 5 months, declined to 32%, and you saw the washout time went from 11 minutes to 26 minutes. Now, you could still argue that that's not a major functional loss. This is a kid that I would probably move to surgery for, and I think most people would. That's not moving in the right direction. It's difficult. I hate doing MAG-3s too often. It is a fair amount of radiation and it is expensive, but in severe cases, I will do them a little quicker just to be sure we don't miss anything. So when would surgery be indicated? These are the types of patients who we certainly consider for surgery. We do not automatically do it based on the ultrasound. Ransley's group had published this a long time ago. Unfortunately, they never really followed up on this in that they correlated the severity of AP diameter with the likelihood of surgery, but there's no absolute cutoff. I mean, you might be able to say over 30 millimeters, but that's still only 60% needed surgery or because of functional decline. And what you don't see in this is the time frame, and some of these kids were watched for over 6 and 7 years. So unfortunately, using this alone doesn't give us a great handle on it. I think we are still arguing as to what is obstruction. Steve Koff's original definition, I think, is reasonably valid, but misses part of it in that he stated that it's a condition of impaired urinary flow that, if untreated, will cause a loss of renal function. My perspective, though, was that it's a condition of impaired urinary flow that limits maximal renal functional development. We're talking about a developing kidney, a growing child. It has to be seen in a developmental perspective. And I do think that that changes your perspective a little bit, in that a kid who is born with 30% uptake and a significant apparent dilation, that child probably need surgery, although Steve would not agree with that. So the degree of dilation is somewhat predictive, but the time frame remains very long and unpredictable. And certainly in the United States, parents are very resistant to long-term waiting with indeterminate outcomes. And then it becomes a little difficult. Can we potentially identify which patients might not resolve their hydronephrosis? And that's one of the approaches we're trying to take, is to predict who's going to take a long time. And we're still trying to define that. This is a nice study from Washington and Gil Rushton's group looking at kids with grade 3 and 4 hydronephrosis, and just as one example of the operative rate of about 38% of those who were on an observational program and had objective changes in function or washout to trigger surgery. And they used serial diuretic renography very well, I think. And then the delayed surgery was in 21% at a mean of a little over a year. And 3 showed decreased uptake and 1 recovered. So there is a small risk to waiting. There is a cost of multiple studies, and in some cases there's a limited follow-up. And this is just a broad look at the various reported rates of late surgery on follow-up. A lot of these have different criteria, but you can see roughly between 20 and 30% are going to progress to where they probably need surgery. So our management scheme for UPJs with moderately severe and severe dilation is I do put them on prophylaxis up until about age 9 months. I get a renal ultrasound and VCUG initially. The ultrasound confirms moderately severe dilation, then they get a MAG-3. If the function's over 40 or 45%, washout less than 30 minutes, then I put them on observation with ultrasounds, and then we stop prophylaxis before a year, repeat the scan to reassess function, and if there's no significant improvement at 12 to 18 months and they remain significantly dilated, that's when we start to discuss repair. Not an absolute, but that's what some parents actually want. And this is just sort of a diagram to show that in terms of monitoring with ultrasound for the severe cases and who might ultimately go to surgery. And then this is just graphically who gets what in terms of the degree of dilation, and this simply fits with limiting the MAG-3 to those with moderately severe and severe. So the major value, I think, of prenatal diagnosis is education for the expectant parent. Don't forget that. And we see a lot of fetal patients, and their parents are very nervous. This is helpful to reassure them. We try to identify those patients at risk for complications of renal injury, develop a prevention strategy, and intervene when appropriate. It's not simple, it's not clear, there's no formulas, but I think using judgment and some of this information might help define these things a bit better. Perinatal decision-making regarding urological abnormalities has to be based on postnatal clinical outcomes, and we're still not there, unfortunately. And this is sort of my simple depiction of this. If it's mild, no worries. If it's really severe, fix it. In between, you can follow up. But it's hard to define something clearly. So I hope that helps give at least a perspective. This is a complex area that continues to evolve, and it's sort of fun to watch. Thanks.
Because of a short time, we have one question or comment, and then we'll move to the second talk. If you can take water, just relax. Any questions, any comment? Okay, so we'll move now to the second presentation. It's the VUR and UTI and the guidelines.
Okay. So this certainly is somewhat related in that we're dealing now just with febrile infection, reflux, and some of the various guidelines that have been published over the last several years. And I call this evaluating the child with a febrile UTI, making sense of the guidelines. Try to make sense. I'm not sure that all of it is consistent yet. So, of course, standard treatment for reflux that everybody knows is continuous antibiotic prophylaxis, awaiting spontaneous resolution, periodic reevaluation for reflux status and renal scarring, and then surgical correction for breakthrough UTIs, persisting reflux after some sort of period of observation, or an anatomic abnormality restricting resolution, such as a diverticulum, although even that is subjective. So a number of years ago, I was asked to write an editorial for the Journal of Urology in challenging the orthodoxy in vesicoureteral reflux, and I called it a perfect storm. Because simultaneously, we were seeing changes in the assessment of the significance of reflux, of UTIs, of scarring, and of the value of prophylactic antibiotics in reflux, and of the potential use of endoscopic treatment, shifting the balance of cost and benefit for surgical, so-called intervention. And I always like the quote from William Osler, the greater the ignorance, the greater the dogma, and we certainly had a lot of dogma in reflux. And that, I think, if anything, has been the best part of this shift, is that it has made us re-examine what we think we know about reflux and infections. And as a result, within a year of each other, The AUA came out with its revised guidelines for reflux, and the AAP came out with guidelines for evaluation of UTI. So what I want to touch on for the AAP guidelines, which have challenged us, is really what do they say, why is there confusion, concern, and controversy, and what can we do? Importantly, there were a number of action statements that are relevant to us in the AAP UTI guidelines. The first is a better definition of what a UTI is. And that becomes very important in this because I suspect we have been evaluating kids who'd never had a UTI, but they were misdiagnosed or thought to have a UTI, and we were picking up kids who were not truly at risk. And really, it should be a febrile child, needs a urinalysis and culture before treatment, and it should be catheterized or a suprapubic aspirate. And this is for kids under 2. And that's the other thing to keep in mind about the AAP guidelines, under 2 years. If it's low risk, just do a follow-up, if not culture. Diagnosis of UTI requires a positive urinalysis and a culture that's positive for greater than 50,000. We've shifted away from the 100,000 ruled from before on a cath or an SPA. And treatment should be based on practical considerations, be it oral or parenteral. Second, and almost the most important action statement was febrile UTIs with UTI, febrile infants with UTI should undergo a renal and bladder ultrasound. And that they argued about, but they did agree that that's what they wanted to do. And that is important. So at least an ultrasound. Action statement 6, though, that got everybody in urology upset is that a VCUG should not be performed routinely after the first febrile UTI. And that was a shift in practice. And then they said that a VCUG is indicated if the renal bladder ultrasound shows hydronephrosis, scarring, or other findings suggestive of high-grade reflux or obstruction. That makes sense. And that further evaluation should be conducted if there is recurrence of a febrile UTI. And that really changed the dynamic that was out there and raised the question, I think, more acutely of, well, how do we want to evaluate kids with a febrile UTI and what do we want to do with the information? And fundamentally, this was based on their observation, their conclusion from their meta-analysis that continuous antibiotic prophylaxis did not effectively prevent recurrent UTIs. And if it didn't, well, then there's little rationale to make the diagnosis of reflux because you don't have a good treatment strategy that's making a difference in what we think is important. And so that was the big pivotal point. Now, I don't need to tell this group the significance of UTI. It affects a lot of kids. It induces hospitalizations, it induces damage and morbidity, and it's costly. A little bit of history, and most of us fortunately don't remember these days, but this was a paper published in 1963, and the number of kids followed after hospitalization for UTI included 8% with progressive renal failure, 22% had persistent or untreated UTI, 18% were dead. And of the males who died, 73% were within 1 month of the initial diagnosis. UTI in children can be extremely serious. Fortunately, we don't see it that much in the modern world, but let's not forget about this. Let's not forget about what Jean Smelly taught us too, and this is work in the late 60s, early 70s, where she initiated the idea of using prophylaxis in kids with recurrent UTIs, some of whom ultimately went on to have surgery, some of whom didn't. And if you look at the change in the incidence of UTI per patient before in blue and after in red prophylaxis, you can see a marked improvement. Now, she was very diligent with these. She did antibiotic level checks. So it clearly demonstrated that prophylaxis can work in some populations, and that's what initiated the modern era of reflux management where we didn't operate on everybody. So fast forward almost 40 years, and we see a number of studies published that I'm sure you're familiar with, starting with Eduardo Garin's in 2006, and a number of others from around the world that demonstrated no benefit for continuous prophylaxis. Now these have challenges. They're not all good studies, and I'm sorry this shifted here, that we'll talk about. But it really pushed everybody in the community to question, well, do we really have a basis for treating reflux, and therefore looking for it? So if there's a lack of efficacy of prophylaxis for reflux, well then why look for it? And that was the real challenge from the AAP guidelines. So why is there confusion, controversy, and some concern about this? And certainly the AAP urology section wrote a response to this, which They argued back and forth if you saw those things. And it really focused on a number of things. And these were the 3 points that we made. We were worried that this approach created an inadequate safety net, that the guidelines were not really relevant to the real world, and the data and the interpretation were flawed and therefore potentially incorrect. So an inadequate safety net, what would the risk be of missing reflux? And overall scarring incidences is low, but is it low enough? Because scarring is permanent, and it can be severe. There's a wonderful article by Malcolm Coulthard, a pediatric nephrologist in Britain, that shows just a snapshot of what happens in some kids after a single episode of infection, and they can have significant scarring. Pyelonephritis and scarring can occur without reflux, but the presence of reflux increases the risk factor of scarring by a factor of at least 2.6. The grade of reflux correlates with scarring risk, so maybe we just need to find the higher grades. And the number of infections correlates with scarring risk. If we wait for the subsequent infections, that's just simply increasing risk. And delays in therapy can be associated with more renal injury. And so in the ideal world, this may be fine to take a non-interventional approach, but I'm not sure about it. Now, everybody sees risk differently, and this is the big thing I have learned in arguing this back and forth, and it really depends upon your perspective relative to UTIs, reflux, and scarring. And I must say, most of us in pediatric urology see the higher risk patients. We see them after they've scarred. We see those in end-stage failure. So we're kind of like the mothers. And the pediatricians, I think, are like the fathers. They just see a ton of kids with fevers and UTIs or mild UTIs. It's less of an impact. And figuring out where we are in this and what's reality is a bit of a challenge. So keep that in mind, that our risk perspective and our risk perception is probably different than those of the pediatricians who wrote the guidelines. And this is just a demonstration, and this was in our guidelines, and also Hans Pohl wrote this paper, that when you look very carefully at kids who'd had DMSA scanning and acute pyelonephritis, the presence of reflux increases the risk of permanent scarring after an episode of pyelonephritis by a significant amount. And that cannot be ignored. A lot of people said, well, you can get pyelo without reflux. True, but the presence of reflux markedly increases that risk. Coulthard wrote another article looking at the effect of early treatment and evaluation is they changed their program of evaluation between the 1990s and 2000s, and a more aggressive referral treatment and evaluation program of children with Febrile UTIs was associated with half as many scars in the refluxing children that you see in the graphs on the right. And that's a significant change, and that's a population group over time. So we can't ignore that by being more aggressive, we seem to be able to reduce scarring. No one has been able to prove that it reduces our risk of end-stage failure, but scarring is not trivial and has lifelong implications. I'm sure many of you are familiar with the Swedish studies where they have shown in several different reports that the number of UTIs and percent of DMSA abnormalities is correlated, and then the reflux grade and risk of DMSA abnormalities is also correlated. So the more UTIs you have, the higher grade of reflux, the greater the chance of scarring. So our concern is that if we are letting a few of these UTIs go through, we're not evaluating early, we're not treating early, that we're going to see more scarring. I'm also worried that these guidelines are not relevant to the real world. Now, all of us would like the real world to be like this. Everyone's happy, everyone's friendly. It's not. And, let's be realistic about it. We know that as physicians, we don't always follow guidelines. Even the pediatricians in this study of AAP practice guideline adherence, only 70% of the pediatricians for whom the guidelines were written actually adhered to them in terms of method of urine collection, and 61% adhered to the imaging workup. So even when the guidelines are out there, people don't follow it. And I must say, I see that all the time. I'm seeing kids being sent to me for the first time after 3, 4, and 5 UTIs. And it just doesn't make sense to me, but it worries me that this may be the real world and these kids are not going to be caught in time. And I ask, and it may be different here, but certainly at home, patients and families don't always remember how many infections they've had. They don't have the necessary documentation of a UTI very frequently. They don't always see the same pediatrician. Many of them are very mobile. And then we do have transient families who have limited access to an informed provider and to their own records. So they're sort of wandering out there in the desert, and that may not be very healthy. There are other examples of where, depending upon what kind of insurance you have, the kind of health care follow-up that you have access to is markedly different. And in our country, that's a big problem, and that's one of my big worries. In the best of all possible worlds, I think the AAP guidelines are fine, but that's not reality. And finally, I think the data and the interpretation are somewhat flawed, and we have to be careful about this. So, yes, we all are trying to practice evidence-based medicine. How good is the evidence? In all of the studies that were used to justify and to be the foundation for the AAP guidelines, there's a huge age range, very few patients with higher than grade 2 reflux in many of the studies, variable culture results. The French study allowed bag urine cultures as a documentation of a UTI. There's a low incidence of initial renal abnormalities, sometimes as low as 6%. There was no assessment of medication compliance, no assessment of voiding dysfunction. And Eduardo Montini, who wrote one of the studies, in a very nice commentary in the New England Journal, said the studies were insufficiently powered for an analysis according to the grade of reflux, yet we know that that's important. So I think we need to be a bit suspicious about the data from which the conclusions were drawn. And there's a problem with combining studies, and this is meta-analysis. We all like doing it. I've been doing it for the guidelines for the last 20 years. But we have to be cautious about it, and that combining data from multiple flawed studies introduces multiple statistical risks. There's a well-known statistical paradox called Simpson's paradox, or the amalgamation paradox, that the result of combining studies of differing sizes, and it's often due to what people call a lurking variable that is not accounted for. And my guess is that in these studies, it's bladder and bowel dysfunction. And when we start looking at the impact of bladder and bowel dysfunction on UTIs and reflux, it makes sense that if you don't account for it, your results are going to be all over the place. And these are just a number of the studies. This is Garin's study. It was powered to detect 20% differences with 60 in each arm. Dropout rate in the prophylaxis group was much higher than planned, so don't know. It was not designed as intention to treat, relatively short follow-up, and it included children from 3 months to 18 years. So a lot of concerns about Garin's study. The French study had a lot of confounders. They observed a relatively high rate of UTI related to an organism sensitive to cotrimoxazole, which is what they were being treated with, in children treated with such antibiotics, which meant they weren't taking the antibiotics. So limited compliance. Voiding pattern was not explored. Most boys were uncircumcised. Sterile bag collection for non-toilet trained and midstream for toilet trained monthly. So if you're using a bag specimen, it's really hard to count on this. And the AAP guidelines even said don't use a bag, but they were willing to take the data from a study that used the bag. The Swedish reflux trial was interesting because it looked at both endoscopic, which is a separate topic, but prophylaxis and surveillance, and they saw a very clear difference between using prophylaxis, where the recurrence rate of UTI was much, much less. So a significant benefit to prophylaxis in the Swedish study, and this was a much higher risk group. I don't have time to go into the details, but they had a lot of baseline scarring. They were categorized for their voiding functions. So this was a much better study of reflux. Part of the problem, and this is worldwide, I think, is that reflux is being decriminalized, and it's being seen as a homogeneously benign condition. Don't worry about it. But to my mind, that's the same narrow view as that in which, in the years past, which we saw all reflux as dangerous. Both of them are at the extreme and are not correct. I think UTI is a warning sign for risk. Ignoring it once may send the wrong message to the family or to the primary care practitioner. I think a diagnosis of reflux improves the ability of the family and the pediatrician to respond appropriately, even if you don't treat it. So I don't see a problem if you know there's reflux and not necessarily treating with prophylaxis if it's low risk, but you know there's a risk, you're going to respond differently. So how can we reconcile all these highly variable study results? Does this apply to all reflux patients or only some? And can we figure out which ones? And so this is sort of what we tried to do in the AUA guidelines that we published, now it's 7 years ago. The biggest issue that came out of this is the impact of bladder and bowel dysfunction, without a doubt. Now we knew this, but from the guidelines, we were able to assimilate a lot of data with all the limitations of amalgamating data. But it showed us such clear differences that in terms of UTI incidence, if you had bladder and bowel dysfunction, had about a 43% incidence on prophylaxis versus 12% if you didn't have bladder and bowel dysfunction. And what we can spend a lot of time defining this. It's either the holder, it's the unstable bladder with urge syndrome, the lazy bladder that doesn't empty. A lot of these terms are out there. We're not great at quantifying it, we're not great at treating it, but we know when it's there. And it has an impact. This is a kid that has always taught me a major lesson. She was a 5-year-old girl, multiple febrile UTIs, never came to evaluation until finally we saw her. Radionuclide cystogram shows dilating reflux, grade 4 on the left. She had a DMSA scan with a 30% uptake with multiple scars. Surprisingly, an outside ultrasound was interpreted as normal, which is a little scary. So we scheduled her for surgery at the end of the school year, so we had 6 months, and I started her on voiding retraining. Right before we operated, we did the VCUG again just to be sure that the reflux was still there, and it was gone. She had learned how to void. She was voiding regularly, we controlled her constipation, she wasn't holding, and we even did another one later just to be sure there was no reflux. So significant reflux associated with scarring can go away if you treat the bladder and bowel dysfunction, without a doubt. And I think it has to be seen as a key element of what we do in reflux and UTIs. Now the other element is the RIVER study. And this was a huge study sponsored by NIH, $7 million, 7 years, multiple sites. It was a 2-year study, incidence and character of UTI as a primary endpoint, scarring, treatment failure, and antimicrobial resistance as secondary. Bottom line on this was it was a 50% reduction in the incidence of febrile recurrent UTI after initial diagnosis if you were on prophylaxis. So statistically very clear. We could have closed this study early, but we chose not to make sure that it was as strong as possible, and I'm glad we did. Correlating issues were presentation and bladder and bowel dysfunction. The problem was that some people felt that this wasn't a significant enough clinical impact, but it's a 50% reduction, similar to what the Swedes saw actually. And just mentioning, if you had febrile UTI to begin with or bladder and bowel dysfunction, had a higher chance of breakthrough. Basic conclusions: prophylaxis reduces the risk of febrile UTIs. Initial febrile UTI presentation and BBD predict more effectiveness. No effect on scarring, but it wasn't powered to do that. Those children with breakthrough infections were more likely to have a resistant organism. No problems. There were limitations. There was a low baseline scarring incidence and a low risk population. Hard to say how much that has an impact clinically. Bactrim or trimethoprim sulfa may have more resistance in the US. We probably should have used nitrofurantoin, but we didn't. So what does it tell us? Prophylaxis is useful. There are minimal risks to it. Bladder and bowel dysfunction is a key risk for febrile UTI. Prophylaxis may prevent scarring from febrile UTI and reflux, but this will need to be more clearly proven in a population at greater risk. So different study. And we could collaborate on these studies. So what do? There's a lot of uncertainty. The AAP guidelines recommend a significant change in practice. Patients with UTI, pyelonephritis, and reflux are here today. But remember, we're treating individual children, not radiographs, not statistics. Children tend to ignore statistics. So what can we do? So is prophylaxis able to prevent UTI and renal injury? Yes, in some children, without a doubt. But it may not be needed in all children with reflux. It benefits those with higher risk of UTI, which means a prior UTI, scarring, and bladder and bowel dysfunction. And keep in mind that a child like this with grade 3 reflux, who's younger, who has bladder and bowel dysfunction, has already had several infections, and has scarring, is a grade 3 refluxer who's very different than this grade 3 refluxer, who is older, doesn't have bladder and bowel dysfunction, has not had any prior infections, and has no scarring. But they're both grade 3 reflux. We have to get away from just treating by grade. We have to treat the entire kid. So if some children can benefit in terms of preventing recurrent febrile UTI and renal injury, reflux should be sought in those at most risk. And who are those? Figure out, is this a real UTI? Was the child toxic? Does the child void normally? Are they constipated? Is the so-called normal ultrasound really true? Are the parents going to come back with another episode? Are you and the parents comfortable to monitor without further imaging. I think if you have that, well, then you can take a less aggressive approach, but with your eyes open and make sure the parents are with you. So I think UTI evaluation has to be tailored to the child and their risk of recurrence and renal injury. It should be a process of collaborative decision-making with parents, pediatricians, and specialists. There is evidence that prophylaxis can be effective in the child at higher risk for UTI. And finally, we should not forget what we have learned about reflux and its risks. Thanks. Sorry? Well, I think they probably need a break more than I do, but I'm fine.
No, I think we will do the third and then we break and then we...
Okay, we'll take the last, I think the last talk, it's okay with you?
Sure.
Okay, so the last talk will be about the Anderson testis or fertilization and the current AUA guidelines.
So, break up.
No, we will continue that.
We'll continue the last session and then we'll take it.
Okay. Are you still with me? All right, a little more on guidelines. You have to understand this is what the AUA likes to do. And it actually, having been involved in it, first started in 1993 with the first reflux guidelines. The AUA has spent an enormous amount of money on guidelines. We only have a few in pediatrics, but that's fine. We're getting more. It's an enormous effort to do this. They coordinate it very well. It's done, I think, as diligently as possible, and the standards are high. And I think it does help, and it sets an example of how we need to look at our literature, analyze it, and apply it to what we do on a daily basis. So I trust most of you are familiar with this, and I'm just going to try to highlight it and give some illustrations in terms of what we do clinically. And this was done using the standard AUA approach of a meta-analysis, but it was done actually uniquely in collaboration with one of our governmental agencies, the Agency for Health Resources and Quality, the AHRQ, which was a unique thing. Their initial guideline from AHRQ was not very good. AUA said, we can't let this go through, so they said, let's partner, and I think it came out much better. A number of basic statistics that we all are familiar with. Fairly frequent prevalence of undescended testes, 1 to 4.5%. At 1 year, it's down to 1 to 1.5%. Certainly seen more often in premature children. And relatively rarely is descent reported after 6 to 9 months. This is a summary statement or chart from a publication used in the guideline in terms of the frequency of undescent. Recognize that this has a degree of subjectivity to it, but it certainly shows the trends. And by and large, the key message is if a testicle is not down by 9 months, it's unlikely to be down. This is an algorithm that we sort of put together based on the guidelines, and we're trying to apply it to a few other things. And I'm going to go through these because I think most of this is pretty obvious to most of you, but if we have bilateral non-palpals, of course, that should immediately raise the question of DSD, and this is disorder of sex development, particularly CAH, and that this may actually be a genetic girl. And in this sort of situation, you want to screen them for that and be thoughtful of it, but also consider checking Mullerian inhibiting substance, gonadotropins, testosterone, dihydrotestosterone, and a karyotype. Doing your early assessment of T can help a lot in the first few weeks because there's the normal surge of it postnatally. We don't do HCG stimulation tests much more, but these can be done to assess testosterone response, particularly if you're going to be doing surgery. But I must say I haven't done one of these in probably a couple decades. Clearly, if hypospadias is present, more thorough evaluation may be needed. If you see hypospadias and bilateral non-palpable testes, that's a kid with DSD until proven otherwise. Ultrasound imaging is not useful in almost any situation. Unfortunately, I still see pediatricians doing this a lot, and this child is almost certainly going to need a diagnostic laparoscopy. And what we would then do is at age 8 months do a bilateral, in a kid with a bilateral non-palpable testis and non-detectable MIS. For instance, you could argue if any exploration is needed. It's really unknown what the false negative of MIS or absence of MIS is. There are too few examples. This was a child who had non-detectable MIS. We went ahead and laparoscoped them anyway and saw bilateral intra-abdominal vanishing testes with, and you can see the vessels here on the left side. These are the iliac vessels, and these are the spermatic vessels that are just fading away as you're going up to the internal ring. You could see the vasa as well. And so this is, we did actually palpate a nubbin on the right hemiscrotum and removed that, and it was an atrophic testis. Sorry, it's a little hard to coordinate here. So if it's not bilateral non-palpable, then, and the kid is older than 6 months, then the recommendation is to refer to a surgical specialist. If they're under 6 months, then continue to monitor and reassess between 6 and 8 months. I actually like to see the kids before 6 months if the pediatrician will send them to me. You establish a relationship with the parents. And if I find a testis that's in the upper canal and then I see them back 4 months later and it's down at the lower canal but still not descended, I'll probably give it more time. I don't know how often that happens, but I don't mind seeing the kids early. I don't feel it's essential to wait until after 6 months. So then if the testis is palpable, then we really have to make the decision as to whether this is truly undescended or retractile, and that I think is an important distinction. My definition and the definition in the AUA guidelines is defined as a testis that is initially extrascrotal on examination, but that can be manually replaced in a stable is the important part, dependent scrotal position, and remain there without tension, at least temporarily. It doesn't have to stay there forever, but it shouldn't be as if it's on an elastic that springs right back up into the canal. I really think this is very dependent upon the skill and orientation of the examiners. I find a lot of pediatricians send me kids who have very clearly retractile testis, but that's fine, and that's very reassuring to the family. There is some concern, and I don't think it's insignificant, that among this group for later testicular ascent or acquired cryptorchidism, and this is a collection of a number of studies that showed incidences between 7 and 32% of acquired cryptorchidism. I'm not sure it's that high, but I do recommend to all the pediatricians in a child with retractile testes that they examine them on an annual basis and refer them back if they have any question. And I have no problem seeing those kids back. But I do think that this is something we have to be thoughtful of and know how to do that exam. Now, if the testis is truly undescended, then we're really looking at orchiopexy, and if still undescended, we would recommend surgical correction. We try to do it between ideally 6 and 12 months. Sometimes it's tough to get them in, and they go a little later. There is no evidence that hormonal therapy has a significant durable value. I think it can change the exam for a while, but most of the data over time have shown that this is not a persistent effect. And my guess is that a lot of the kids in whom it supposedly worked actually just had retractile testes. Today, inguinal and scrotal approaches are both being used. I have tried both. I would say be cautious with the scrotal approach. I don't think you can get as good a mobilization, even if you're very vigorous with your retractors. And it can be difficult to deal with the hernia sac if it's present. And I've had a number of kids that I thought for sure I'd release the testis fine, And when I saw them back in follow-up, it's in the high scrotum. It's just not quite as good as I would like. So I'm not super enthusiastic about the scrotal approach, except for the kid with a testis sitting in the high scrotum or just below the pubic tubercle. Guidelines certainly recommend follow-up for cryptorchidism that needs to include counseling as to the possible impact on fertility. Our best knowledge is that unilateral undescended testis is going to have effectively normal fertility all the way up to the child with bilateral intra-abdominal who probably is not going to be naturally fertile. They can certainly have sperm harvesting. And there's very limited data to support the use of hormonal therapy to enhance fertility potential, which of course would be the whole benefit. And there's still some argument about it, but I think most of the data are going to turn out that there's little value, and it is being used relatively uncommonly. Now, if you have a kid where the testis is non-palpable, we do refer them for surgery. We do not do adjunctive imaging. Even MRIs cannot prove the absence of a testis, and that's the unfortunate part. And so with a child in the operating room, after a careful exam in clinic, I still re-examine them under anesthesia. We try to do this again between 6 and 12 months. And in our older series of laparoscopic evaluation of undescended testis, almost 18% of kids who were non-palpable in the clinic had a palpable testis in the OR under anesthesia. I don't see it as much anymore. I don't know whether I'm getting better at examining these or not. If I feel a clear nubbin representing an atrophic scrotal testis palpable in the scrotum, then I would consider a scrotal exploration. But I've been fooled on these a lot, and I end up digging around the scrotum for a while and then go do the laparoscopy. So if I'm not absolutely certain that it's just a nubbin, I'll do the laparoscopy and then decide what we see. If we find a testicle intra-abdominally, and I'll show you some examples, if the child's under 2 years and the testis is less than 2 centimeters from the internal inguinal ring, I do a primary orchiopexy, leaving the spermatic vessels intact. Otherwise, I do a 2-stage Fowler-Stevens orchiopexy. Some of my partners will do a 2-stage Fowler-Stevens in any intra-abdominal testis, which is okay, but I really think that you can get these down, and it just seems intuitively better to have the vessels intact. But that's a little difficult to say for sure. So at this point then, if we feel a nubbin, we would do an exploration. Again, my preference is laparoscopy, and this has I've been doing these since the 80s, and we did a number of early reports on the value of that, and I really don't feel any reason to do an inguinal exploration first. So just as some of the things that you can find in a child with a non-palpable testis, obviously on the left, this is a nice example of a testis sitting right at the internal ring, very close to it, good vessels, vas is clearly evident. In contrast, this is a testis that's actually sitting up. This is the liver edge, and this is above a dysplastic kidney way up in the retroperitoneum. This was not a salvageable testis, but it tells me that you have to look widely. And if you don't clearly see the vasa and the vessels, and particularly you have to see the vessels, then you don't know where that testis is. And do not assume it's absent unless you have seen, and really this is what I would call the intra-abdominal vanishing testis, which constitutes up to 20%. You have to be comfortable that you're seeing a cluster of vessels that fades away as it's approaching the internal inguinal ring. Here's the normal on the right, the vas and the vessels going out the ring, and here's the abnormal on the left, but you can clearly see these vessels. If you see the vessels going out through the canal, and it's a non-palpable testis, then that's typically a non-viable nubbin that you'll find in the scrotum. I like to remove them to just be 100% sure, but I've never found a testis when the vessels are thin like this when you compare them to the normal on the opposite side. I have on one case in several hundred found a perineal ectopic testis that I couldn't feel, and those vessels, though, were actually very robust. So it told us, okay, there may be a testis. We went and looked, and that's why I still explore these, just to be sure. In the situation where the testis is intra-abdominal, as I mentioned, I actually measure this. I put a little ruler in. I've been doing that for a long time, and it has helped. And over the years, although unfortunately this has not been published, that if it's more than 2 centimeters above the ring, we had a definitely higher failure rate for leaving the vessels intact. So if it's greater than 2 centimeters above the ring, I will clip them. You can see here's us about to clip it, and then here's the testis. These aren't great. These are older images. They're a little contrasty. And then we're going to mobilize this testis on the second stage on the pedicle of peritoneum surrounding the vas deferens, which is right here. If it's within 2 centimeters, then I'll do a primary orchiopexy with the vessels intact, and this is just us lifting up the testis. Here are the vessels. We peel the peritoneum off and mobilize this fairly aggressively, but we've had good success at bringing them down in that approach. And so we've talked about this, and then again, if the vessels are entering the internal ring, we do the inguinal or scrotal exploration. If they're blind ending vessels and vas, then we just close and we're done. It's a little hard to navigate these. So, key points for the guidelines is we would anticipate, and of course the guidelines are largely directed at pediatricians as well as urologists, is we hope that the child will be referred at about 6 months for evaluation by a surgical specialist. We would certainly want them to refer an acquired undescended testis when suspected. Boys with retractile testes should be evaluated annually. We don't need to see them. I think the pediatricians can, but we should be available if there's a question. Hormonal therapy is not recommended and certainly is not being used much in the United States, if at all. And if there's no descent by 6 months, then surgical orchiopexy is recommended, and we do that between 6 and 12 months ideally. And then boys with cryptorchidism should be counseled as to long-term risks of infertility and cancer. So that's a very brief summary of the guidelines, and hope that's helpful. And maybe we've caught up a wee bit on time. Thank you. Well, if I truly feel they're retractile, based on my definition, to where I can bring them down and I can let go and it doesn't immediately glide back up, I don't operate on them. I think I will have some kids where in the office I can't be sure. It's always high. Then we talk about it, and if the family is anxious, if they want closure, then we would discuss doing an orchiopexy, and that for sure I would do as a scrotal orchiopexy. Because I don't think you need an inguinal. But I really try to avoid doing those kids. I think almost all, 85, 90%, I can be very comfortable differentiating. If I'm not sure, I bring them back once, 4 months, 6 months later. And if we are still uncertain, then I do them. Because then I don't think they're retractile, I think they're truly undescended.
What do you do with a patient who has usually asymptomatic high-grade reflux, one infection of these 4, 5, 6 years you are taking for it, and the same person who usually high-grade reflux in the stomach?
Yeah. So, what to do with the child with asymptomatic high-grade bilateral reflux? Typically, it's a boy. Yeah. First of all, I like to use the DMSA scan to know, do we have healthy kidneys? My criteria for non-intervention would be healthy kidneys. If I see scarring or significant functional abnormality, then I'll probably lean more towards repair.
And we're talking about that age group of 5 to 7 or so, where I mean, you can wait a little longer. Already I would have addressed the question of bladder function and tried to deal with it. If they're still not doing well, and we'll use biofeedback, a variety of other measures, then I keep them on treatment. They're the ones who we need to worry about. The truly asymptomatic ones in high grade, we have a long, hard discussion. And my worry is that they're going to show up with a problem at some point. And I don't know whether it's going to be in 6 months or 6 years. I have seen a handful of kids present with their first infection with high-grade reflux as older children or teenagers. We've seen the kids, the boys, with bilateral high-grade reflux who are completely asymptomatic until they're teenagers and then go into urinary retention and renal failure. So I don't know whether we could have done anything about it, but I have to, because again, my risk perception is some of the bad ones. But I'm hesitant to let them go. High-grade reflux, I think, has negative consequences. And endoscopic treatment, I really don't use it much at all, if at all. I have, my worry with endoscopic treatment is its lack of reliability. So, you know, even in the supposedly the best of hands, you're talking about 85, 90%. That's 10 times less successful than open surgery. You have to do more VCUGs. And more importantly, we don't know how long the effect lasts. And so it's like saying, well, I've never had an accident, so I'm not going to wear a seatbelt in the car. And you've taken away the protection and you don't know when the infection might occur. And I just did a kid, now granted a case, an N of 1, but this was a memorable kid. I'll remember him for the rest of my career. Bilateral grade 5 reflux, followed since birth. He's age 10. Never had any documented infections until relatively recently. Was injected with deflux 3 times. Continued to have massive bilateral reflux. Started to go into retention, had terrible bladder spasms, had to have a catheter. His creatinine was 0.8, and he's not a big kid. DMSA shows diffuse scarring on both kidneys. Supposedly no infections. He was the hardest reimplant I've ever done. And he was a reimplant and tapered. His ureters looked like the colon. And digging out probably $10,000 or $12,000 worth of deflux was hard. So I mean, those cases are anecdotes, but what worries me is that a very good pediatric urologist was managing him that way. And I think our mindset has shifted enough to where people are saying, oh, he's fine, don't worry about this. Well, we'll inject some deflux, maybe this will help. He should have had his reimplant when he was 3.
Thank you very much. To follow on that point, what's your approach to those kids with what I presume of hope, having a kind of a legitimate dysplasia versus an acquired scarring post-urinary infection, especially those males who tend to have a high grade investment reflux, diagnosed with prenatal screening and have a high rate of especially on the prognosis aspect.
I mean, that's a great area, and you may have seen it if you're interested. I could send you, I have it here. Gil Rushton and I wrote a review on congenital and acquired reflux nephropathy. They are different entities, I think. We don't know whether the abnormalities associated with congenital reflux and no infection are from the reflux or from a coincident developmental abnormality. Don't know. The things that I at least pay attention to are the fact that almost all of these are boys. It's typically high grade. Yes, they do go away quickly, or more quickly it seems. So I give them that opportunity, unless the function is, unless they're having trouble, either infection or metabolic problems, and that's uncommon. But they all have some degree of bladder abnormality, and the Swedish urodynamic studies have shown this in kids with high-grade reflux, most of them have abnormal patterns of voiding. And I think it's maturational. I think they have an immaturity and a discoordination or a detrusor sphincter dyssynergy that goes away. Don't know why. It would be really cool if we could figure out how to get rid of it, and maybe alpha blockers might help. I don't know.
This could be due to the yo-yo effect of the high reflexes and circulating back.
Yes, and that's I think an important element of it, and we often talk about that, and that has in my discussions with various teams, we've wondered whether we should do those kids even earlier. And it goes back to your question of the high-grade reflux. Does it change bladder function? It might. They become a big dilated, never emptying bladder. And so we've had that discussion. I don't know. It might be a study we could do of looking at kids with high-grade reflux. What's their bladder function at age 10 if they were corrected young versus corrected old?
Have we had any kind of a long perspective kind of follow-up trial just to see if they do have a resolution will be the effect on the ultimate of these functions? Do we have any kind of?
Thank you very much for nice presentation. And my question, is there any risk from leaving an open testis in the scrotum and spare the baby exploration the scrotum?
Yeah, I think that's a good question, and I don't think there's any real risk. Most of the data, several reports, you will find viable germ cells in 7 to 10% of these nubbins, and that was our results in our old paper from 92 or whenever it was, and other papers have shown the same thing. In theory, I remove them partly to just, I'm very cautious, and I want to know that we don't have a testicle hidden somewhere that we've missed. I think it's rare, but that's why, and I make a tiny incision in the scrotum, you dissect a little, you push down, the thing pops up, you pull it out, and you cut it off. That's about it. So it's not much of an exploration. But I would never fault someone for not doing that. I think it's reasonable. And it's a good question, but that's one of those sort of just being cautious.
Yeah, last question.
لا في واحد قبله في أمية قبله لا one.
Only one question for you.
So what we will do for a patient with monotonous syndrome far away from the will you do for a second bilateral at the same time?
Oh, yes, good question. Is if I have bilateral intra-abdominal testes that need Fowler-Stevens, either because of location or age, yes, I do them bilaterally. I used to stage them when we first started doing this, and we realized this kid's getting 4 operations. And especially today with the issue about number of anesthetics being uncertain. So I clip them both and bring them both down. By and large, I don't have a good alternative. I don't do microsurgery. We don't have a microsurgeon readily available, and there's very limited experience. I think 8% function is not worth salvaging. I used to save them. I don't think it's worth it. I think what the real difficult question is, do you reimplant the other side? And I would. Because I think when you relieve that pop-off valve, that the grade 1 reflux will be more, and then you have a solitary kidney. You've already put the kid through 1 operation. And what we actually did a little paper on this, is we do a laparoscopic or robotic nephroureterectomy and contralateral reimplant. Those I will put a stent in now.
Conservative, or we still have to go for
Yeah, I think you can be non-interventional. I'm not sure what conservative management is. Hardy Hendren would teach me that surgical repair is conservative. You're conserving nephrons. But I do have a very in-depth discussion with that family, because you're not going to see them back, and we have no good data long-term. The other element that I factor in is whether they have renal scar, because the only good data that are available on kids moving into adulthood with reflux is that those with scarring seem to have more trouble during pregnancy. The biggest concern is that they're not likely to get, as you've described it, an infection from, say, age 6 or 7 until they get to sexual activity in their 20s. And then they're out of your hands. And I think the family has to know that. Oh, I'll offer it. But I would, a grade 2 like that, I would not. I'd be very hesitant to operate unless the parents said, yes, we want this fixed.
Okay. Okay, I think we'll conclude this session. We'll give you a break for 20 minutes.